Looks to me like there's still just 2 of us.
Yeah. There's about 15 registered.
Okay, that's good.
Hopefully they all figure out how to get in.
Yeah, maybe just be a matter of timing, because it was like doing nothing, and then, you know, when you came on and said I can't hear, you couldn't hear the sound, it just spontaneously let me in. So I don't know,
Oh, okay.
it hit a certain time before the talk or something.
Mhm.
I'm not going to speculate anymore because I don't understand machines. You're in BC, correct?
Yeah, yeah,
Hmm.
yeah. Enjoying our lovely summer.
Yes, yes. Well, you know, I try to think of it this way: it washes the virus down out of the air to our feet.
Okay, it's starting to get very jungle-like where I live. Everything's just growing like crazy.
Yeah,
I still think
yeah.
I'm in a rainforest for sure.
The other thing I wanted to mention is I do have a meeting at noon. So I'm going to, I don't know how long you've booked for this, but I'm going to have to be promptly sign off after an hour. I hope that's
Okay,
okay.
yeah, that's fine.
Because most of your sessions aren't longer than that, are they?
No, it's just scheduled for an hour. So I'm going to do a little thing at the end about just telling people about our other webinars. So feel free to drop off for that if you need to.
Okay. Looks like we have another person, so that's good.
Ah, yes, great.
Are we able to tell who's connecting, or?
Yeah, if you click on the attendees
Oh, okay.
tab, you can see the names if they sign in with their name.
We'll wait for at least a couple more.
Yeah, for sure.
So it's interesting. So I actually swim. I've got arthritis and I swim every day to stay mobile. Of course, in March, everything slammed shut, as you know. So my aunt and uncle fortunately have an outdoor pool, and so I'm commuting up to them to go for my swim. But I get to swim in weather like this, for example.
Oh.
So yeah, I know. I feel, you know, in March it actually snowed on me once.
I don't think I could bring myself to even get in the pool.
Fortunately, they keep the water nice and warm, so that's good. But yeah, it's just bizarre how this is affecting our lives in ways that nobody would have ever imagined.
Yeah, my partner says he's even missing the gym, and he hates the gym. So
He misses eating it. Oh, good. Now we've got 4. Awesome.
okay.
Do you think we should wait for, should I start when we get 6, or maybe everyone will all sign in at once?
Yeah, probably give it till 4 or 5 after the hour,
Okay.
and then I'll start.
I see I still have the other date on this. May 22nd.
Well. Okay, we have a few more people coming on board now.
Awesome.
Give it a couple more minutes.
Everyone's prompt.
Welcome everybody joining us. We're just going to give it a couple more minutes before we get started. Waiting for a few more people to log on.
Have you had a lot of these virtual seminars yet, or?
Yeah, we'd actually started doing them even before the pandemic hit, just to reach a few more people in the winter.
Right.
So this is probably our 5th one this year.
Okay. Well, that's good practice, because I don't think, like you said, we're going back to live meetings soon.
So we've already had one question come in that you can consider while we're waiting.
Sure, I can't see the question. Is there a way I can open that? Oh, open the chat box, I guess.
There's a question box above the chat.
I've got chat, I've got attendees.
Oh, okay. Maybe you can't see them all. I'll just read this one to you and you can think about it.
Okay.
If and when there is a virus, is there a difference in risk for a live or dead virus used?
If there's a vaccine, you mean?
Oh yeah, sorry, I misread it. If and when there is a vaccine, is there a difference in risk for a live or dead virus used?
Yeah, that's a great question, and maybe I'll answer that as we go along. Remind me if I don't, so that more people can hear the answer to that. Yeah. So, but remind me if I forget.
Yeah, okay. Okay, well, I think we'll get going and other people can join as we're going along. Hi everyone, my name's Fiona Lewis and I'm pleased to welcome you to this webinar hosted by AAMAC. AAMAC is a leading funder of research into bone marrow failure diseases in Canada. Our organization supports patients and caregivers across the country who are living with aplastic anemia, myelodysplastic syndrome, and paroxysmal nocturnal hemoglobinuria. So I'm the patient support liaison for BC and Alberta, and I invite you to visit our website to find out more about our services across Canada. And I'm pleased to introduce our speaker for today's webinar regarding COVID-19 and bone marrow failure diseases. Dr. Heather Leitch is the Director of Hematology and Oncology Research at St. Paul's Hospital. She completed a PhD in microbiology at UBC in 1992. She graduated from medical school at UBC in 1995 and completed a hematology fellowship at McGill University in 2000. She completed post-fellowship training with the lymphoma tumor group at the BC Cancer Agency in 2002 and currently holds the position of clinical associate professor at UBC. Dr. Leitch has been a member of the Hematology Oncology group at St. Paul's Hospital since 2004 and actively participates in research projects and clinical trials with a focus on hematological malignancies. Recent publications co-authored by Dr. Leitch have focused on the treatment of iron overload in patients with MDS and other acquired bone marrow failure syndromes, HIV-associated lymphoma, and relapsed myeloma, MDS, and lymphoma. We're going to have lots of time for questions at the end of Dr. Leitch's presentation. So as you're listening, you can type any questions you have into the question box that hopefully you can see on the right of your screen. You may need to click the little arrow next to questions for the box to open up. And I'll read them out at the end for Dr. Leitch to answer. And we'll also at the end unmute all the lines so you can just ask her your question verbally if you prefer. So with that, I'm going to turn it over to her to begin the webinar. Dr. Leitch.
Hello, everyone. Thank you for joining in. And I have to apologize about canceling on the short notice on May 22nd. I was quite spectacularly unwell that day, but I'm better now. So I've been asked to do a virus update, and I have to confess to you that I'm not the hematologist that knows the most about coronavirus. My approach to it is basically to know enough to keep myself and my patients safe, and otherwise to ignore it and hope that it goes away. But hopefully we can go through, a few basics that you may or may not have heard by now. And this is actually what the coronavirus looks like under the electron microscope. So it's got all these projections that help it to bind to things. Okay, my slide doesn't seem to want to advance. Oh, here we go. So what is coronavirus? So it's called a beta coronavirus, or beta COVID. It's one of 4 genera or genuses of coronavirus of the subfamily Orthocoronavirinae in the family Coronaviridae of the order Nidovirales, for those of you who are biology fans. And so this is what it looks like. So it's got this nucleic acid here, which of course runs the program of the cell, and it's surrounded by probably a lipid membrane, and then it's got these protein spikes which help it to bind and invade cells. So they're positive sense single-stranded RNA viruses of zoonotic origin, which means they originated in animals that are not human. We're animals too. So the envelope refers to this covering. The positive sense is just the way that the nucleic acid turns, and it's an RNA virus. And in the older literature, the genus is also known as group 2 coronaviruses, in case you've been reading and didn't know that. So why is it called corona? It's named after the so-called solar crown. So when you take those sort of projections and look at the virus under the microscope, they appear as these kind of solar flares around this circle. I think it also should be referred to as an actual crown. Maybe it's the king of viruses or the queen. And so why are we susceptible to this particular virus? So SARS, severe acute respiratory syndrome, is coronavirus 2, SARS-CoV-2 is a novel virus. So what viruses do is they mutate, and the flu virus does this, and this is why we need a new flu vaccine every year, and we can't just be vaccinated once and be immune forever. So all the features of this novel virus do occur in related coronaviruses in nature. And as I said, it's thought to have a zoonotic origin. And because it's new to humans, we have no immunity. So with the flu virus, we are immune to parts of it, although, as I said, it does mutate, and so it can evade our immunity partially, which is why we have the yearly vaccines. So this guy's pretty rude. So this is to tell you that virus can travel sorry, I'm gonna go back, on droplets, and the droplets can actually travel up to 37 feet, if that's not shocking. So, you have to wonder why we're only staying 6 feet away from people if people are doing this. Hopefully not too many people are doing this. So I just thought, sort of within the talk, I'd show you some of the Gastown graffiti. I live in Gastown, and there's been some really amazing art that was up. It's unfortunately now come down with the reopening of the businesses, but the businesses were boarded up and people just drew these amazing things on them. So how is it transmitted? This is incompletely understood. Probably primarily spread during close contact within 1 to 2 meters, which is why we stay 2 meters apart, by droplets produced by coughing and sneezing. Saliva does carry large viral loads, and an uncovered cough, as I said, can travel up to 37 feet. It can also spread by touching contaminated surfaces, including the skin, and then touching the eyes or nose or mouth. While there are concerns that it may be spread by feces, the risk is believed to be low. It is most contagious in the first 3 days after the onset of symptoms, but spread may be possible before symptoms appear and in later stages. And so viruses are kind of sneaky. And so like the flu, people are contagious for up to 2 weeks before they actually develop symptoms. And this is the importance of staying away from people. Even if they seem fine, they may be infectious. So people have tested positive up to 3 days before the onset of symptoms and up to 8 days after the resolution of symptoms. We're not sure why they were tested before they developed symptoms. But asymptomatic transmission has also been identified, so from people who have never had symptoms. And the European Center for Disease Prevention and Control says one person generally infects 2 to 3 other people. And I actually have a little video that I'm going to show you on that at some point during this. So the virus does survive for up to several days on surfaces, and so this is very important for prevention control. And also importantly, pets have tested positive for COVID-19. So authorities do advise washing your hands after contact with animals. So if you're petting the cat or the dog, do wash your hands. So diagnosis. Infection can be provisionally diagnosed by the symptoms. Confirmation is ultimately by what we call reverse transcription polymerase chain reaction, or RT-PCR, of infected secretions. And so this is a bit of a fuzzy thing, but basically, in our cells, DNA is transcribed to form RNA, and then it's translated to proteins. But this is an RNA virus, so how do we amplify that RNA to find out what's going on? So there's an enzyme called reverse transcriptase, which transcribes the RNA to DNA, which then can be amplified, and then it can be sequenced and identified. So it is a DNA-based test. So it's actually kind of amazing that we can get the results within 24 hours. So I wasn't very good at capturing this video, so I'll show it a couple of times, but this is basically an index case and shows what happens and how the spread occurs and why it's so important for us to lie low. So the alternative . So you can see quite a difference in the spread. I'll just let that run one more time. Maybe it's going to run. Oh, okay. I guess it's not going to run. So this is what flattening the curve is all about. So, we can do this, in which case, we don't have the healthcare resources to take care of the people that are sick, or we can flatten the curve, and this is the increasing healthcare capacity. And so at the beginning of the pandemic, the healthcare system was making plans such as turning the convention center into a COVID hospital so that they would have enough beds to take care of everyone. Fortunately, in BC, we have been lucky enough that we haven't had to go there so far, as opposed to many other countries and even other parts of the country. So I thought this had some animation, so let me just see. So this is what happens if we don't do anything. And this is what happens if we lie low and listen to our provincial health officers. Trying to get to the next slide, but it doesn't want to let me go. Okay, so if we have inadequate mitigation, we have this initial surge in mitigation, and then we have a resurgence. Which is what we're seeing in some countries already, including south of the border. And we certainly would rather not see that in British Columbia, but there may well be a second wave, which is why they're not just, lifting restrictions blanket-wise, why they're being careful about it. So in terms of treatment, there's no vaccine, as you know. There are no specific treatments. Development efforts are underway. Taking the over-the-counter cold medications, drinking fluids, and resting may help symptoms. Depending on the severity, oxygen therapy, IV fluids, and breathing support may be required. And the use of steroids may worsen outcomes. Here's another thing from Gastown. So, in terms of the treatments and the vaccines, I think I have a slide later on, but let's talk about complications first. So complications can happen to really any of the body systems: the respiratory system, acute lung injury, acute respiratory distress syndrome, severe ARDS or SARS, shock, septic shock, cardiogenic shock, cytokine storm. So shock refers to lowering of the blood pressure. The body's not able to maintain its blood pressure. Cardiac complications, so cardiac injury, acute coronary syndromes, pericarditis, which is inflammation of the membrane around the heart, myocarditis, which is inflammation of the heart muscle itself, arrhythmias, abnormal heart rhythms, hematologic, thrombotic events, what we call diffuse intravascular coagulation, which is basically the coagulation system kind of going out of control and consuming coagulation factors and platelets, for example, low cell count, cytopenias, kidney problems such as acute kidney injury, neurological problems, most commonly dizziness and headache, but there can be impaired consciousness. Hypogeusia is alterations in taste, and that can be an early sign. Hyposmia is alterations in smell. Stroke and seizures can also occur. GI, diarrhea is common. There can be liver injury, sort of oncologic or cancer-related, febrile neutropenia. Some treatments, of course, that are given for cancers, including blood cancers, can place patients at increased risk of severe infections. So in terms of patients with blood cancers, the American Society of Hematology is collecting information on patients with blood cancers who developed COVID. And this includes the severity of the infection, the patient demographics, what blood disorder, what treatments have been received. And we are actually participating in this at St. Paul's. There's no identifying patient information. It's just, okay, this person developed COVID. These are the facts about them, and then they'll do these analysis and give us better information as we go along. So what about research efforts? Most other clinical trials are currently closed to enrollment because we're trying to minimize contact between people, including research staff and the patients. And we're also trying to minimize any investigational treatments that may or may not place patients at risk. Funding for COVID research is being prioritized by many of the funding agents and also by our local research ethics board. Anything to do with COVID-19 is being expedited through the approval process. And the federal government on May 16th did announce $450 million in new funding for research. So I like this one. We're in this together. The world is beautiful, and so on. What about severity of disease? It ranges from asymptomatic to life-threatening and even fatal, as we know. People who are at increased risk of severe disease are people over the age of 60 or with a comorbidity. So is MDS or aplastic anemia a comorbidity? It is, but does it place people at increased risk of COVID? We don't really understand that well yet. Usually viral infections are mediated by the lymphoid immune system, and MDS affects the myeloid immune system. But, having said that, there's a lot about immunity that's not well understood. So I think that we can at least consider MDS and aplastic anemia to be comorbidities, and most patients, I think, would fall into the over 60 age group, though not everyone. So severe disease is caused by a cytokine release syndrome. So cytokines are the little hormones that cells use to talk to each other and that mediate inflammation. And so the inflammation is really what mediates the cell damage. It's not the virus itself. So you get tissue mayhem such as fluid leak in the lungs. And so cytokine cytokine blockers, for example, medications that block the interaction of this particular cytokine, IL-6, interleukin 6, with its receptor, are under study and may be of value in this disease. Other treatments that are under consideration include using convalescent serum, which is basically collecting plasma, which contains antibodies from people who have recovered, to treat patients with severe disease. And you hear varying opinions on whether or not that works. So as far as I've seen from the medical literature, there's no evidence yet that that helps. However, if you watch, I can't remember if it was W5 or 60 Minutes, they were, saying how great this is. Although the person that was saying how great it is someone in the US who actually has a financial interest. So I think the jury's still out on that. They are having clinical trials of several existing medications. For example, there's an antiviral that's used to treat hepatitis C that seems to have an effect against COVID. And there's a clinical trial of a vaccine that's opened in the UK. So how can we protect ourselves? The best way is to follow the instructions of the public health officials, even though segments of the population are ignoring them. Washing our hands with soap and water frequently does more than wash off the virus. Soap actually inactivates viral proteins, so it inactivates the virus. And in fact, you'll hear about blood products being solvent detergent treated. So basically they're treated with soap because it inactivates viruses. Try not to touch your face. That's easier said than done. Cover coughs and sneezes with the inside of the elbow so that you're not putting virus on the hands and then touching things. Wear a mask in public, not necessarily because you're at increased risk compared to the general population, but because I personally think that everyone should be wearing a mask in public. We hear varying opinions about whether or not that's helpful, but in my opinion, it's unlikely to harm you. I actually have a cloth mask that you can just throw into the wash. How effective is that at preventing virus? I don't know, but if someone sneezes on me 36 feet away, maybe it'll protect me. Surfaces, so remember that the virus can stay active on surfaces for days, so wipe them down with disinfectant. What's very effective is a 1 in 10 solution of chlorine bleach in water, and use that to wipe down things like countertops and doorknobs and TV remotes and light switches and car keys and anything that people may have touched and then touched other things. This is the little instructions on hand washing. So we all think we know how to wash our hands, but it actually is surprisingly complicated. So if you look at step 3, this is washing in between our fingers, which we may not remember about. And then step 4, you have to do the other fingers, and you should actually go to the back of your hands as well, which is not really shown well on this. 5 is you're basically scrubbing your tips of your fingers into your palm, and then you go around your thumb. That's step 6. Step 7, I'm not sure how that differs from step 5. Maybe 5 is the knuckles and this is the fingertips. Then we rinse, then we dry our hands, then we use the paper towel to turn off the sink, and now the hands are clean. So basically a similar procedure with disinfectant. Soap and water is more effective than disinfectant, but we're only near a sink so many times during the day. And I think this is my favorite graffiti of all, is be kind. So that might be my last slide on this topic, sorry. So there was a question already about, a vaccine and whether what's more unsafe, a live vaccine or a killed vaccine. And I think, we don't really know until we actually have a specific vaccine. In general, patients with lymphoid disorders are not supposed to receive live vaccines, but some vaccines are less live than others. So it depends on how well they've inactivated. And, like anything in medicine, it's sort of a potential risk versus potential benefit and balance. So, I think that we would be very lucky to have a vaccine, hopefully within the next few months, and we'll see where this goes. It may be that this just dies out over the coming months like the Spanish flu did in 1918 to 1920, or it may be that we're stuck with mutations of this every year like the regular flu, and that we may have to have a new vaccine every year. So I think that that's a big unknown right now. And so maybe I'll pause there and see if there are other questions at this point.
Yeah, thanks, Dr. Leitch. We do have one other question in the chat box here. It's, how do people with MDS fare if they catch COVID-19?
Yeah, so it's obviously a very important question, and I think it's unfortunately something we don't understand well right now. We've been fortunate enough within our own groups to not have any MDS patients who have actually contracted COVID. I know that's probably a different situation in other provinces, but I haven't really heard an update on that. I was telling Fiona that right now I'm actually supposed to be at the European Hematology Association meeting in Frankfurt, but of course no one's traveling right now and the meeting has gone virtual. I did see that there are a number of talks on COVID-19 on the virtual agenda, but the conference is just opening today, so I haven't had a chance to watch those. So I could certainly update Fiona if there's anything significant with that, but at this point I think it's an unknown. I think the bigger issue perhaps is that many MDS patients are over the age of 60, and that seems to be an age group that's at increased risk for contracting severe disease. And so that's part of the importance of lying low.
Okay, thank you. And we have another question here. Would you consider someone with anemia and high platelets on low dose of steroids to be at seriously increased risk?
Yeah, I guess that depends on the dose of steroids. I mean, if it's like 2.5 milligrams, probably not. But if it's 20 milligrams, I'd start to be concerned. But, again, it's always a risk benefits balance. And so obviously that person's on steroids for a reason. And so I think that that would be an assessment for their physician to know why are they on steroids, how likely is the disorder that's being controlled by the steroids to harm them versus how likely is COVID to harm them.
Okay, and that person has just added that it's 10 milligrams of prednisone.
Okay. It's kind of a moderate dose, so I'd be more concerned than with 2.5 milligrams, but I think that I would pose that question to the physician that's treating you for whatever disorder. Yeah.
Okay, and another question, are there any breathing exercises one can do that may help if you catch COVID-19?
Oh yeah, wow, wouldn't that be great? Not that I'm aware of, but I think if any of you smoke, stop right now. So that's the best thing you can do for your health in general, not necessarily just for COVID. So it's not, I don't think, necessarily a matter of lung volume. It's more a matter of the cytokines and how out of control they get and how much lung damage they cause. I think the other question that feeds into this is there was some talk about the virus being taken up into endothelial cells, which are cells that line the blood vessels in the lungs, by something called the ACE2 receptor. ACE stands for angiotensin converting enzyme. And of course, many people are on ACE inhibitors or ACE receptor blockers for hypertension. So how does that affect COVID? Does it help protect people from COVID? Does it make them more susceptible? Again, there have been a number of studies done without clear results. And so, it doesn't seem to, at this point, affect the risk for the virus either way, but I think that that's an unfolding story as well. But of course, we do know that, hypertension and cardiac disease is a big risk to your health. So if you're on an ACE inhibitor, don't stop it just because of this talk. Just maybe watch going forward and have discussions with your doctor going forward.
Okay, I'll just open the line to see if anybody has a question they'd like to ask. But if there's a lot of background noise, I'll mute it again because sometimes that can just ruin everyone's experience. So, don't know if that worked. Just a sec. Okay, unmuting people. Does anybody want to ask a question right now?
Yes, I'd like to ask a question.
Okay, go ahead.
Sorry, that's just my computer's got a. I have 5q deletion. Now, why does it take so long when after you have the deletion for the MDS to kick in? I don't know how to phrase that, but it's, if you can understand what I'm asking.
Dr. Leitch, are you there? Oh. I've unmuted.
Okay. Can you hear me? Okay. Fiona,
Yeah.
sorry about that. What did you mean by for the MDS to kick in?
Well, you get the 5q deletion at some time in your life. You
Okay.
don't know when, and it seems to be years afterwards, it seems to that you get MDS.
Okay. Yeah, so I think that's a really good question. And I think whoever figures that out will probably get a Nobel Prize in medicine. So I think that we are, learning about mutations and how they might lead to MDS at this moment as people are doing more mutation analysis. So, as I'm sure you know, there are, dozens of mutations that are associated with MDS and sort of how they initiate MDS and what other factors are needed to sort of promote the MDS development is not something that's really well understood. And, even, okay, for someone who's got del5q and a diagnosis of MDS, and if they've got significant anemia and they're taking lenalidomide, how does lenalidomide really work? That's something that's still just being worked out too. So like many things in medicine, we know that a medication works before we really understand the molecular mechanisms. But I do know that that's certainly a very active area of research going forward. And, the other part of that is this, CHIP, clonal hematopoiesis of indeterminate potential, which you've probably heard a lot about over the past couple of years. And so basically, if you do a bone marrow biopsy on someone with a cytopenia, a mild cytopenia, and you find a mutation that's associated with MDS, but they don't meet the diagnostic criteria, that's CHIP. And so how many of them go on to develop MDS and over what time frame and what things promote that, I think is something, again, that's not well understood, but will hopefully be better understood going forward.
Okay, thank you.
I'm not sure if that answers your question, but I'm not sure I can really well. I have a little video to watch if there are no other questions right now to show you, and I also have a few slides on iron overload if you're interested. So let me just pull up the video if I can. So bear with me, it's actually in an email which I wasn't able to import it into my presentation. So you have to watch this for the subtitles because unless you speak Arabic. Okay, here we go. Here we go.
تردنا أسئلة كثيرة عن الRCO، وفي هذا الفيديو راح نقدم لكم شرح عن ما هو هذا المعدل. كيف نعود إلى حياتنا الطبيعية؟ سؤال يتبادر إلى أذهان الكثيرين من الناس، وهذا السؤال أحيانا يرتبط عند بعضهم بإجابة لها علاقة بمعدل اسمه R0، 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 RO. هذا المعدل تهتم به الهيئات والمراكز والمنظمات المعنية بالأوبئة. طبعا نتكلم هنا عن الوباء المتعلق بفيروس كورونا الجديد المسبب لمرض COVID-19. هذا المؤشر كيف نفهمه؟ كيف نقرأ؟ هذا المؤشر إذا كان أمامه الرقم 10 يعني أن سرعة الفيروس تنتقل من شخص إلى 10 أشخاص، وخلال فترة حضانة اللي هي أسبوع إلى أسبوعين ممكن ينتقل من 10 إلى 100، لأن كل واحد راح يعدي 10، وال100 بعد فترة أخرى سينتقل منهم إلى 1000 لأنه أيضا كل واحد راح يعدي 10، وهكذا. طبعا إذا كان أقل من ذلك سيكون الانتشار أبطأ وأقل سرعة، وإذا وصل إلى الواحد أو أقل منه هذا هدف تنشده الدول لأنه يعني تحكم بسيط. نتخيل القلق اللي ممكن يصيب الأشخاص لو كان أحبابه من حوله بهذا المعدل للانتشار، كيف ممكن يسري ما بينهم ويسبب انتشار مريع وخطير. كم كان هذا المعدل في العالم؟ كان هذا المعدل في العالم تقريبا يسجل مستويات ما بين 2.5 و3.5 وأعلى من ذلك في بعض الفترات، ثم يتم التحكم في مجموعة من الدول ويتغير، إلا أنه سجل في بعض الأماكن في العالم مستويات 8، وهذا رقم مخيف ومقلق ومرعب جدا. كم كان في المملكة العربية السعودية هذا المعدل؟ سجل هذا المعدل في المملكة العربية السعودية مستويات ما بين ال4 تقريبا، ثم بدأ يتحكم فيه من بين 2 و3، ثم بدأ بالنزول باتجاه الرقم 1، وهذا رقم بالاتجاه الجيد. ما الذي ساهم في تحقيق ذلك؟ الحمد لله في المملكة الإجراءات التي وضعتها الدولة الاحترازية والاستباقية الناجحة والممكنة من الوصول إلى هذه المستويات الجيدة وثمارها الحمد لله، إضافة إلى تمسك المجتمع والتزامه في مظهر ينم عن الوعي الكامل في المجتمع بكامل أطيافه. وإذا استمرينا بإذن الله بهذا الاتجاه سنواصل جني ثمار ذلك. دائما إذا تمسكنا بالسلوكيات الصحية ومن أهمها التواعد الاجتماعي، النظافة لليدين، ترك المسافات الآمنة فيما بيننا وبين بعض، تغطية الوجه بالذات الأنف والفم، كل هذه الأمور وغيرها من النصائح التي نتواصل فيها ستكون بإذن الله لنا معنا. كل هذه الأمور سهلة. هل ممكن أن يعود هذا الرقم أو هذا المعدل للارتفاع؟ ممكن، لكن هذا الأمر بأيدينا. لو استمرينا نحافظ على ذلك وأثبتنا فعلا أن كلنا مسؤول، بإذن الله سنواصل النجاح ونجني ثماره حماية وصحة للمجتمع. هذه النصائح واثقين جدا أنها بأيديكم بأمان.
Okay. Just go back to my presentation.
We have one more question about COVID-19 before you move on, if that's okay.
Sure.
It says, would you agree that for those at higher risk, it really won't be safe until there's a vaccine or effective treatment?
Yeah, I agree, unless the virus suddenly dies out. It's possible. I mean, that's what happened eventually to the Spanish flu. It just died out and went away, but it took time. And so with the Spanish flu, there was a first wave and then there was another wave. Hopefully the global measures that we've taken during COVID-19 will, prevent or attenuate a second wave, but we just can't be sure. And I think, all pandemics up till now have had a second wave and sometimes the third and the fourth. For example, if you think of the Great Plague in Europe in the Middle Ages, I mean, a third of the population died, and in England, half of the population died, and there were 3 or 4 resurgences. But I think the advantage we have now is that we can communicate with each other. In England in 1300, you didn't know what was happening 20 miles down the road, but now we have all this technology to talk to each other, not only in other provinces, but in other countries of the world. So I think that, if we can all sort of pay attention to that and work together, that hopefully this will not turn into a long-term thing. But I do personally think that we need a vaccine or a treatment going forward for sure.
All right, thank you. That seems to be it for questions right now. If you want to go on to the second part of your presentation.
Oh, sure. So I have a couple of slides in this presentation, and I do have another slide set for people who are interested. So this is called the MDS Iron Road, and it's actually an online tool that we developed for the diagnosis, workup, and management of iron overload in MDS, and this is from the Canadian Consortium on MDS. You see these buttons that say English and French. Unfortunately, I haven't yet done the French version, but the English version is up and running and actually was accepted for presentation to the European Hematology Association. So I did that little recording. And so here's our logo, CCMDS. And there's the poster. And I think those are the only two slides I had on that outside of my other presentation. So I will just pull that up and show you how it works since we have a few minutes. Looks like I didn't put a title slide here, but as any of you who are receiving transfusions know, this is this thing on my screen is covering the little man, but you can imagine he's there. So iron accumulates from transfusions, so 200 to 250 milligrams of iron per bag of blood. It can accumulate in the organs, and a moderate transfusion requirement of 2 units per month ends up with 100 units over 4 years, which is 20 grams of iron. So that's too much, and iron overload results in the presence of toxic redox active iron, which means that iron has the ability to transfer electrons, unlike many molecules, or actually it's an atom. And so it results in free electrons, which can be toxic to tissues and organs. So historically, the importance of iron overload management in MDS has been controversial, although analysis from the Canadian MDS Registry did control for 4 measures of patient performance status and evaluated survival from first red cell transfusion. And so that is a way of minimizing 2 potential sources of bias. The performance status being that one of the criticisms has been, well, you chose the better patients to receive iron chelation therapy, so of course they're going to live longer. And evaluating from first transfusion dependence instead of from MDS diagnosis, minimizes lead time bias. And it did show superior survival in patients receiving chelation, and several analyses matching for characteristics thought to affect prognosis supported these findings. So this is the whole group, and you can see that the patients who had attention paid to iron control had better survival than those that did not, and this was significant. And this is a matched pair analysis where we matched for age, IPSS-R score. We used IPSS score to look at the lower risk patients in this analysis, but as you may be aware, if you use the IPSS-R, that upstages some patients. Number of red cell units transfused per month, and also time from MDS diagnosis to onset of transfusion dependence, and still there was a significant difference in survival. We now have the, sorry, I've got my little note on this still, the Telesto trial, and so this was a randomized controlled trial of the chelator deferasirox versus placebo, and unfortunately this trial, which started out at 600 and something patients, was reduced to 210 patients because it was enrolling slowly. And what happened over the years was, because of the controversy, people like me who believe in the importance of iron control didn't want to randomize their patients to receive placebo, whereas people who were dubious about the importance of iron didn't want to enroll their patients at all. So the trial was no longer powered to detect its endpoint, which was overall survival. And so the target enrollment was reduced by 2/3, and half of placebo patients actually withdrew from the study and subsequently received chelation, which obviously could confound the results. And the mean age of study patients was 10 to 15 years younger than most MDS patients. But despite all these, there was a significantly superior event-free survival in patients receiving iron chelation therapy. So you can see the separation of the curves, which seem to separate more over time. This is 5 years from enrollment. So to my way of thinking, this study might actually underestimate the impact of iron overload reduction in MDS. And so I'm just going to present a case to you. 56-year-old man who presented with fatigue. Physical exam was normal. Here are his counts. His hemoglobin is 199 with an MCV of 102. Ferritin was 800. His EPO level was 168. The smear showed macrocytosis. Bone marrow aspirate showed increased cellularity, 1% blasts, erythroid dysplasia, and ring sideroblasts present. Cytogenetics were normal male, and so the diagnosis, now the classification has changed, but at that time was refractory anemia with ring sideroblasts, IPSS low risk, and he was requiring a transfusion of 2 units every 3 weeks. So the first question is he eligible for agents that induce transfusion independence? And I chose to give him EPO, an erythropoiesis stimulating agent. Why? Because lenalidomide is not approved for normal karyotype MDS in BC. He lived remotely, so immunosuppressive therapy would have been difficult. Azacitidine is not approved for lower risk MDS. Stem cell transplant was considered, but deferred because of the good prognosis and no sibling donor. And iron chelation therapy is considered to be a supportive care, although I personally think it's active treatment for reasons I may have in these slides. I don't quite remember. But if we can use an active treatment and induce transfusion independence, then we can phlebotomize to use iron. And also we should always consider a clinical trial, but didn't have one available at that point. So some of you may be familiar with the MDS ClearPath, which is an online algorithm developed by the Canadian Consortium on MDS, which is used to diagnose, risk stratify, and guide treatment management of MDS. And there's information on all the agents we use in MDS, including erythropoiesis stimulating agents. And so this is showing part of the treatment wizard, which guides us to treatment recommendations for patients with symptomatic anemia with EPO less than 500, consider ESA. And I hope I have the informational panel here. And so it has the information on EPO and also DARBO, what the initial dose is, what to increase it to after what period of time, and we can close this. So sort of based on this, we actually updated Canadian guidelines for the management of iron overload in MDS. And so there is information on iron overload in the MDS ClearPath, but it's kind of, basic information. This delves into much more detail, and that's where we developed this MDS Iron Road from. So this is the original Iron Road. So the last spike of the Canadian Pacific Railway was driven at Craigellachie, BC in 1885, and here we go. This is the last spike. So this is just outside Revelstoke, right at the summit of the Rogers Pass. And so in the time it took to bring the railroad from the East Coast, it took to get that far from the West Coast through the mountains. So Lord Strathcona, and so this marked the completion of the Transcontinental Railroad, and the railway's completion fulfilled the commitment made by the Canadian federal government to British Columbia, which stipulated a railroad be built by joining the Pacific province to central Canada, and was a big part in BC's decision to join Canadian Confederation. Why Iron Road? Because some of you, unlike my residents, are old enough to know who Gordon Lightfoot is, and to know the song The Canadian Railroad Trilogy, and the line is, for they looked in the future and what did they see? They saw an iron road running from the sea to the sea. So it's kind of my little patriotic name for this algorithm. So if you can believe it, my residents don't know who Gordon Lightfoot is, which I think is shocking. So I give them homework and tell them to go watch the YouTube video. So in terms of some general comments on iron overload, iron is much more interesting than we realized it was even 10 years ago. There's an online article called Iron is the New Cholesterol, and describes how iron is central to many processes and disorders. And this is a quote from that article, such as the Faustian bargain that has been struck by life on this planet. oxygen, iron are essential for energy production, but may also conspire to destroy the delicate order of our cells. Life was designed to exist at the very interface between iron sufficiency and deficiency. And also there's another article that describes how iron is an ancient signaling molecule. So iron was actually involved in signaling billions of years before the existence of ATP. Adenosine triphosphate is a substance in our cells that's critical for signal transduction from protein to protein and to the cell nucleus to activate the transcription of various different genes. But iron actually was billions of years before it. So environmental conditions and porous hydrothermal vents where heated mineral-laden seawater spews from cracks in the ocean crust created a gradient in positively charged protons that served as a battery to fuel the creation of organic molecules and protocells. So here we have the sea floor and we have this vent spewing hot mineral-laden water, and it sets up this gradient that allows the formation of lipids and proteins and nucleic acids, which eventually formed cells. So basically iron was key to the formation of life on Earth at all. So this is the overall algorithm for the iron road. And so there's two modes, the iron road, which is this, and the IR Express. And so this talks about lower risk MDS. This is an information panel. Higher risk MDS, we first assess first eligibility for stem cell transplant. Then is the patient transfusion dependent? Do they have a reasonable life expectancy? Do they have documented iron overload? If not, we monitor. There's our little video camera. And if they do, then we have to consider reducing iron overload. And the first question is, can we induce transfusion independence with MDS treatment? And this gives us lots and lots of information on iron overload and transfusion. And this gives us information on iron overload in the setting of stem cell transplant. If we can induce transfusion independence, then we can do phlebotomy, and we have information on how to do that. If not, then we go to the information on chelation. We also have links to references, future directions, and levels of evidence and grades of recommendations. And now I'm just going to show you the IR Express. So this takes you through a series of step-by-step questions that result in a treatment recommendation. So the first is he eligible for therapies that induce transfusion independence? If we say yes, that will take us outside the algorithm to the MDS clear path, where we can get information on EPO in his case. But here we click on received a therapy that can induce transfusion independence. That's my hand there. And so the next question, transfusion independence achieved with a reasonable hemoglobin. And in his case, yes, his hemoglobin went to 115. So we click on this. Can we advance? So going back to the case. So with EPO 60,000 units, he had a hemoglobin of 115, and he actually had a ferritin over 1,000. And that's where I could have started phlebotomies, but didn't, because I wasn't as savvy back then. A year later, he remained transfusion independent. Ferritin's coming down. He had 6 years of transfusion independence with improved quality of life. And then he presented with an exacerbation of anemia, a repeat bone marrow showed stable MDS. He developed a regular transfusion requirement. Ferritin increased. And so now we're going to go back to, is he eligible for therapies? Well, he's not, because we didn't have other therapies at this point. So then we go to the information on chelation. So we started on deferasirox, the dispersible formulation, which was the option at the time. Had a creatinine bump, stopped. Creatinine dropped, but not to normal. Started on deferoxamine, the infusional chelator, but unfortunately developed sensory neural hearing loss, so we stopped that medication. I did manage to get lenalidomide for him off label, but unfortunately that didn't agree with him. And while we were waiting for luspatercept availability, which will be very helpful in patients with ring sideroblasts, he actually started deferriprone, which is off-label use. This is not indicated by Health Canada for use in MDS because of a risk of agranulocytosis. However, he developed arthralgias requiring narcotic medications, so the deferriprone was stopped. L-trombopag, which can be used in aplastic anemia and also has some activity in MDS, is actually a very strong iron chelator. It's also not Health Canada approved for this indication. But unfortunately, you know, after many arguments with his private insurer, you know, it took some time to get hold of this. And by the time he got this medication, he died of refractory congestive heart failure and infections, both from iron overload at the age of 70, which is far too young. So I really apologize for this. I left all my notes on it. So we do know that cardiac events in MDS patients are increased, particularly in patients with anemia. So this shows there's cardiac remodeling in patients who have a hemoglobin of, you know, a lower hemoglobin as opposed to a higher hemoglobin. We also know iron overload is associated with development of cardiac events, and that cardiac events are the leading cause of non-leukemic death in MDS. So if you put aside MDS and transformation to AML, cardiac events are the highest cause. And so here's MDS and AML, and here's cardiac events. So we actually looked at this in our patients, in our lower risk MDS patients, and we looked at episodes of coronary artery disease, congestive heart failure, and arrhythmia. And we found that, and this was maintained in a multivariate analysis, that our patients who were transfusion dependent, this is just during their period of transfusion dependence, if they received iron chelation therapy, there was a longer time to first cardiac event than the non-chelation patients. And there's actually a really interesting review article by Francesca Vinci, for those of you who are scientifically inclined, about how iron contributes to atherosclerosis and leads to coronary artery disease. We also know that an iron-rich environment enhances the growth of microorganisms. They use iron to grow and replicate. We also know that iron overload leads to functional impairments of neutrophils, macrophages, and natural killer cells. And we know in stem cell transplant that iron overload is a risk for infection. We also know in lower risk MDS from our US Medicare registry study that patients who were transfusion dependent had a higher rate of infections. So we looked at our patients with lower risk MDS during their period of transfusion dependence, and although patients had similar neutrophil counts and similar number and types of infections, the ones receiving chelation had a longer time to first infection than the ones not receiving chelation. I see that I'm being a little bit wordy here, but I think I've just got a couple more slides. This slide shows that iron overload decreases in vitro the number of erythroid cells that are formed. And we also know that patients treated with iron chelation therapy, a substantial majority of them have an erythroid response or an improvement in their hemoglobin, even with transfusion dependence, so up to 1 in 5 patients. So we know that transfusion independence is associated with superior survival and quality of life in low risk MDS. Following ESA failure, the treatment options have to date been limited. Transfusion dependence leads to iron overload, which is associated with inferior clinical endpoints. The number of chelators we have access to is unfortunately limited, and use of them can be limited by side effects. So in future, we'll hopefully have access to more treatment options to modify disease course in MDS and induce transfusion independence, which should optimize survival and quality of life. And there are several agents in clinical trials right now for lower risk MDS and also for higher risk. Wherever possible, iron overload should be delayed, minimized, or reversed using novel agents with or without phlebotomy. And when that's not possible, reducing iron overload with chelation should be considered. That's what basically this algorithm is all about. And so you can access it. I hope you can see that. The log on, you have to put in your browser. It doesn't work if you put it in your Google. You have to put it at the top, mdsironroad.org. The username, it's not quite live yet, so it has a username and password because I'm incorporating people's feedback from the EHA presentation, and then we'll go live. It's less expensive to do it that way. So the username is Iron Road without spaces, and the password without spaces is Make Iron Great Again. And I think that's my last slide. Thank you. So thanks very much, and a pleasure to talk to you guys, and I'm happy to take questions about iron anytime now or in the future.
Thanks so much, Dr. Leitch, for those 2 informative presentations. I know you have to go, so I'll just quickly see. Oh, there's a question for me that I can answer. But I'll just thank you, Dr. Leitch, again, and wish you luck in the conference. And if you are able to share any new learnings from the conference with AAMAC, we'd be happy to put it on our website.
Perfect. Thanks a lot.
Okay, thanks again for your time.
Okay. All right.
Bye-bye.
Bye.
For the others still on the line, the question is, will the presentations be available on our website? We've recorded the session, so that will definitely be posted, but I will also see if Dr. Leitch can share the slides, and we can try and put those up there too. So I just want to thank everybody else for participating and remind you that we are going to be continuing to have some webinars in June, and then we'll probably take the summer off and have more scheduled for September. So please keep an eye on the AAMAC website for those. And in the meantime, you can always contact our office if you need any support that we can provide. And there's a thank you. Yes, thanks everyone, and we'll talk to you again soon. Bye-bye.